This event a reality. Your commitment to excellence shines through every detail. To our speakers and panelists, with their expertise and vision. To our delegates, your participation. Dr. Narmada, she is an MD in medical education.
दो और दे दो.
She's a critical
Thank you
and
very much.
intensive care medicine intensivist, head of critical care department at hospital. She's a secretary of the critical oncology committee, and area of expertise are mechanical ventilator, airway management, and sepsis. She's one of our international faculties. Dr. Rajesh Mishra, he's the past president of IACCM. He's an intensivist, internist, and area of expertise is sleep apnea. He's a director and honorary consultant of Shelby Comprehensive Care Clinic. We also have our international faculty, Dr. Brendan Madden. He's from London. His affiliation is as professor. He's a professor at St. George's Hospital, London. He was appointed as one of the first clinical professors of cardiothoracic medicine in UK in 2007. His area of expertise is his unique skills and training equipped him to manage right heart catheterization, pulmonary hypertension, and endomyocardial biopsy, acute complex large pathologies, all facets of cardiothoracic intensive care, VA ECMO. I would like the delegates and the audience to ask questions on mechanical ventilation to Dr. Jenny Cardenas and Dr. Rajesh Mishra, and direct your questions about to Professor Dr. Brandon Madden and Dr. Geeta George. Thank you.
So thank you very much for having me in this very important meeting. I'm very happy to be here. It is my first time in India, so I will be more than happy to answer your questions.
हाँ सर.
Likewise, thank you very much for the privilege of coming back to India. It's
So
always
we are ready for the first question. આ નીચેથી કરવાની અને તું નીચેથી અહીંયાથી બધાને આપવાની છે ને આપી દે હા એટલે શું ઉપર રહેવાનું છે કે નહીં હા
So, if nobody asks, we can ask ourselves and start the session.
I think we have few questions from the audience.
Yeah, that will be great. Otherwise, we have a lot of questions and answers.
Okay.
So we can ask hemodynamic question to you, and we can ask mental question to them.
Good morning, sir. Good morning, sir.
Please.
Sir, in patients of ARDS, we generally keep high PEEP to maintain the oxygenation, but sometimes we have seen that it causes subcutaneous emphysema. What will the PEEP titration in such patients? Because we are worried that very high PEEP will increase the emphysema.
Yes, of course. Okay, thank you for the question. It is very good. Actually, we used to use high PEEP, I think that's 5 or 7 years ago, and we find a lot of barotrauma and a lot of myotrauma in the diaphragm muscles. So nowadays we know that higher PEEP is not very good for our patients. We need to be more aware for all of the other things that we can do in the patient, and to know if the patient can be recruitable or not, because that's another very important thing. So we need to specify, to find the subtype of the patients that can be respond adequately to the PEEP, if it's a higher PEEP or low PEEP, and to taking care in account the other strategies to better oxygenation in our patients.
So just to take that question, there are two in the question. There are two questions. One is how high PEEP is high PEEP, and second is if somebody develops cervical emphysema, what to do. So we do not increase PEEP blindly to nowadays, and we titrate the patient according to subtype, the PEEP responsive or PEEP non-responsive, depending upon the lung compliance. And if patient responds to titration of the PEEP, then only we increase the PEEP. If patient lung is very stiff and compliance is not improving, if majorly titrate the PEEP, we don't increase. What we should be doing is to cervical emphysema. Is cervical emphysema, there is no pneumothorax. I will not increase the PEEP, but I will not be very much worried about the PEEP if patient is responding to PEEP. So basically, cervical emphysema is sometimes subpleural bulla, or maybe due to the airway injury, it leaks to the along the airway and then it goes to subcutaneous space. It doesn't mean you have subcutaneous emphysema, that means you have lung injury as well, or maybe pneumothorax as well. But you need to be very careful. Most of the time nowadays we take help of ultrasound in titrating the PEEP, then we go above up to 8 or 10. So we need to divide the ARDS into subtype of the PEEP responsive or according to the compliance, or PEEP non-responsive and according to the time. So better those patients who do not respond to titration of the PEEP, let them put on chronic position. That will be better to do rather than increasing PEEP and causing lung damage.
In the ARDS patient, we give prone position. So pros and cons of prone position meditation in ARDS patient.
Okay, great question. Well, the prone position is not for everybody. Like all of the strategies, they are not fit for all size. So in the prone position, we because of the PROSEVA study, we know right now that it is better for patients with a PAFI less than 150. That's the first thing. The other is that if the patient can, we need to be sure that the patient can respond appropriately to the prone position, and we can know because of the ABG at the first 4 to 6 hours. But the other thing is that not just one episode of prone position could be benefit our patient. We need to do at least 2 to 3 times the prone position to know if the patient could be better with the oxygenation. What else? Well, the pros is a lot of, I mean, all of the physiological advantage to prone the patient, but the cons is probably our mindset that we are aware for the all of the side effects, because we are not like or we are not, it is not a routine tools that we are using, but after COVID, we are, I don't know what about you, but we all get a lot of experience doing that, and nowadays we just need 2 to 3 persons to do it the prone position. That's for my answering.
So your question is that how
Pros and
long
cons.
prone has to become?
Pros and cons.
Pros and cons of prone position. So pros is that most of the time the lung is compliant and not very stable. If you put the patient on a prone position, response. The response, that means it's likely that the patient is going to better. So, but the thing is that with time we have learned that typical trial for 12 hours prone and then you put the patient on supine, then again prone, or that doesn't work. We have to do prolonged period, maybe 3, 5 or even longer cycles of prone position. The only thing is that it requires manpower. That means there is 3, minimum to 5 people to prone position. When you put the patient on a prone position, you can take out the lines. You have to be careful. That means some responsible person between. Further, patient injuries are very common. Very people take care properly about the braces spine. If you take care, then it's not. We have done prone position for 7 or more than 7 cycles, continuously 18 to 20 hours. Still, the patient has been fine, but you need to be really into it, more vigilant, more careful. While patient is prone, another thing is you have to keep the patient completely steady and many times paralyzed. So, but that's a requirement, because if you have to prone the patient, you are not able to ventilate properly, you find that's a part of the parcel of the period.
So continuing the same question, while we supervise the patient from proning, there is an episode of hypoxemia again. So what would be your opinion, rotation, or advice for? And one more thing to prediction, with IP patients on ventilator with their areas, how do you go for the fluid management, particularly IVC should be IVC carried or something else?
Yeah, well, thank you very much for the question. I mean, I think the great thing about intensive care is that the patients are often very individual with all sorts of other parameters. From our point of view, when we're dealing with complexities like this and we have to think about management strategies, then we're very keen to try to get as much information as possible. So in terms of getting that information, we have a variety of approaches. We do rely, when we're looking at cardiac function, very heavily on echo, if we can, either transthoracic if there are good views, or transesophageal echocardiography, which is particularly helpful. When we're looking at the right ventricle in these patients and trying to determine whether we should give any support to the right ventricle, then we're looking at things like the right ventricular morphology, the pulmonary artery systolic pressure to a lesser extent, but then in particular, areas of function. So we're looking to see how close to 34% the fractional area of change is, the FAC, and whether or not the TAPC is compromised for longitudinal function. Less than or equal to 1.4 is our cutoff. If we have further concerns, we deploy PA catheters, and then we look at the resistance, because we're interested in lots of different things, but certainly the resistance across the lung circulation, and whether if we had to give, for example, vasoactive compounds, would they be tolerated, and would that just increase the shunt fraction? So the very broad answer is that you raise a really important issue, a really important question. But from us, we look at a variety of issues when we're looking at hemodynamics in these patients. not just their central filling pressures, but potentially the pulmonary vascular resistance derived from PA catheter measurement in conjunction potentially with either transthoracic POCUS echo. We prefer formal echo rather than point of care ultrasound, and also potentially transesophageal. We're quite keen on that.
Answering your question about when we put the patient on from prone to supine, they are very likely to get hypoxic in their system. The answer is that you quickly do the procedure and put them on again prone before they become hypoxic. They give you at least 60 minutes to 90 minutes of time. So most of the time when patient is very sick and I know that the moment I put them on supine position, they are going to develop that. I do not give much time. Just do the quick procedure, cleaning and whatever purpose we have done, and better to put them on there. I have also fluid therapy in the RDS. So when my patient is even unstable, we restrict the fluid. That's one strategy we follow. We don't give fluid at all. And if at all, basically hypertensive, we rely more on the fluid challenges, which itself is a big topic. If patient is fluid responsive and hypertensive, both, then only we give fluid, otherwise we avoid giving fluid, and definitely we do not give fluid in the RDS patient, which causes more capillary and retain more fluid. So that's what we do about the fluid therapy.
Yeah, I mean, we would share similar views. I mean, obviously, you all appreciate here, you're all experts, that giving too much fluid is bad. But equally, we have to be very careful because we want to maintain good renal function, good hepatic function, good gut perfusion. But you are right. I think if you're going to give fluid, you have to be very careful and selective as to how you respond. A lot of centers in Europe use lithium dilution to look at stroke volume response, but that's often difficult to interpret because if the patients are shut down peripherally, you may not get very good arterial traces, so you may not be deriving an accurate response in terms of the actual readings that you're getting from LIDCO. But I agree entirely that we would be judicious, I think is the word, and absolutely share your view.
So my question of the prevention. So the ARDS, ARDS protocol
respiratory rate is on optimum rate, in which tidal volume is approximately 4 ml per kg, and still the patient is retaining the CO2. So what is the measures you can do for the CO2 removal, or you can directly, pH is going down, then we can directly go for CO2 removal, or we can plan the ECMO or such kind of thing?
Well, obviously, I'll defer to the ventilation experts, but just from our practice,
Yes.
and I'll let these good people give much more information than I can give you, but from our practice, what we're very keen to follow the standard protocols, the international protocols for ARDS management. So we're very signed up to that. In terms of the strategies, clearly you've heard about fluids, infection, treating other issues that impact adversely on the lungs. Do we use other modalities? Sure. I mean, there will be times we will bail out if we're failing with the standard protocols, trying all the usual techniques, as you've heard about prone ventilatory support, you've heard about APRV, all the usual techniques. If we're failing with those, then we would bail out with VV ECMO. I mean, that's something that we're very keen on. But making that decision early if you're going to do that. Do we use CO2 scavengers? Not really. A few patients over the years have benefited from that. And in Europe, there was one of our cardiothoracic surgical colleagues, Mr. Penny Callis, who was very interested in putting in IVC cannulas to extract CO2. We don't routinely do that. So if people have gone through the very extensive ventilatory strategies available and we're still losing, and we think the lung disease is progressive and it's appropriate for the patient, then our default would be VV ECMO. But I mean, obviously, these good people will know much more about ventilatory strategies than I do, and they'll address other issues. But we would follow the information given by experts to my right, and if that information was not leading to successful resolution, we would go in early. In the past, pre-COVID, we used to use oscillator ventilatory techniques, but that is very rarely done now at all. So that's not something that we would engage in.
Madam, any special view, or any madam, for CO2 removal?
Yeah, no, the CO2 removal for me and for my perspective is that it can change just the value of the CO2, but not the result of the patients. No change the mortality, no change the days on ventilation. So it is kind of like You can even like makeup, yeah, like do some makeup in the AVG, but at the end is not in a very good result. That's my opinion.
So this is a very common problem in the COPD patients. Those who are retaining the CO2 and we are putting on the ventilator for the ARDS.
Yeah, well, for us, we look at those patients early to decide that. And again, obviously, we seek experts to my right. And once we've gone through the various techniques, and if those experts say there's nothing else we can do, then under those circumstances, we would try to identify early those candidates for VV ECMO rather than waiting till they get into a worse situation, you know. So I think we would share your view. But again, it just demonstrates to me the importance of a holistic team approach with experts in ventilation, all sorts of other colleagues involved. But for us, that would be our approach. And if we're thinking about VV ECMO, we think about it early rather than just waiting. Oh, sorry, I beg your pardon. Sorry.
I want to ask Dr. Brandon a question, even though I'm here. Basically, this CO2 dialysis for removing carbon dioxide with these new dialysis machines which have the CO2 removal system. Do you use those? Because in India, it is quite expensive for us to use ECMO. So do you think that has a role?
Thank you, Professor. From our point of view, we have not used those devices. We are aware of them, and we've had people talking to us about them, but we have not used those devices.
So just to jump into the question, we really need to assess we are dealing with the ARDS or we are dealing with COPD and ARDS. If it's the ARDS and CO2 retention is concerned and pH hypoxia is not there, only CO2 is concerned and pH is going below 7.20 and with optimum setting of ventilation and toning and not able to reduce the CO2. And only CO2 retention is a concern where it's affecting the pH, bringing down my pH to below 7.15. I can think for ECOR as removing only CO2 because it's less invasive. And even what we do in India a little bit of the play, and we do dialysis machine. We use pediatric heart
Oxygenator.
to remove CO2, and it really works. It really works very well. We use it for 24 hours, and many times it has saved a lot of patients from the invasive procedure. Just to put the educator and we do this. So I think some of the picture we can show you. This is one thing which we do as a surrogate if we want to reduce the cost. If hypoxia is concerned, I will not think any of these devices. I will directly go for the ECMO if that is the concern. But very precisely, if CO2 retention is a concern, if ECOR is available, I'll do that. If it's not available, and everything is selling, including prone position, even I'm not able to tide over the effect of respiratory stenosis, hyperkalemia is a concern, then probably I will go for the removal of CO2 through the pediatric heart lung
Oxygenator.
oxygenator.
I mean, that's very interesting. We have not experienced in that, which is very...
Our experience in India will be around more than 1,000 patients on this.
Wow, that's great. That's great to learn.
We use just dialysis machine and the simple flow of 150 ml of blood pass to this and it really works very well.
And how long would you have a patient?
We go for it almost for 16 hours, 18 hours for that, and if needed to change the membrane.
So 16 to 18 hours.
Yeah.
And then would you repeat that, or and how long could you keep doing that?
Most of the time, either it responds in 24 to 48 hours,
Okay.
or we have to shift to the
Okay, so that's great. That's, you know, we were saying yesterday, you always learn, so that's a good learning point for me. But our policy is we go through all the various maneuvers you've heard, but we go through them rapidly. And if we feel that we're going to bail out, we go straight for ECMO. But that's good. I'll have to learn and read.
Yeah, good morning. I have this brief two questions, maybe in one-liner. Sir, what in your practice, if you have to choose one parameter for volume responsiveness, dynamic parameters, which parameter that you would rely on? I'm talking about advanced hemodynamic monitoring.
I talked about, did you say ECMO, or were you talking about, sorry?
No, advanced hemodynamic monitoring.
Yeah, what do we
Yes,
look at?
volume responsiveness, dynamic marker of volume responsiveness. There are a lot of markers like SVV and PPV and so forth. what you are using and you're relying more that, okay, I would use more, this parameter a bit more. I know there is no straightway answer, but what you are using in your practice?
Thank you. If we're hemodynamic monitoring in general in ITU or in ARDS or
No, in septic shock patients.
in septic shock, okay. So what we tend to do, I mean, if you can get away with non-invasive or relatively non-invasive assessment, that's very good. So looking, for example, like cardiac performance, what the left ventricle is like, what the left ventricle is empty, whether it needs to be filled, etc. But specifically in septic shock from a hemodynamic standpoint, we're looking at systemic vascular resistance and SVO2. So we're keen to try to normalize the SVR as much as possible. And we do that either using LITCO if we're happy that we're getting representative traces, because you want to protect patients from invasive catheters if you can. But if we're not able to do that, if the patient is not giving us good traces peripherally, then we would put in a PA catheter and measure SVO2. We find that's a very, as lots of people do. But I think if you are not somebody who wants to put in PA catheters, then things like LITCO, if you have that in conjunction with so-called standard maneuvers like lactate levels, acid-base balance, urine output. And in fact, I was chatting to one of your colleagues yesterday, I believe, who was the first, she was the first, I believe, accredited consultant in intensive care in Gujarat. And she was saying to me that she bemoans the fact that people don't go back to the so-called old-fashioned ways of clinical examination and basic tests, which I think, in my opinion, she's right, actually. So, we'd look at the basic things. What's their skin perfusion looking like? What's their pulse like? What's the urine output like? What's their acid base like? But if we wanted to titrate inotropes, for example, then we would want to have a good knowledge of what their SVR is. I mean, you can, as you know, calculate it. If you've got a CVP line in, you can look at an arterial line, you can calculate it. If there's a LITCO and you can guess the cardiac output, but then it becomes a bit of a guess. But that would be our approach. And I mean, others have different views on that. But, our approach would be clinical evaluation, LITCO. If we're not happy with LITCO, we're not happy with echo assessment, we would put in a PA catheter, and we'd be looking in that situation at SVO2, cardiac output, and SVR.
Thank you. And one last question. Do you use mechanical power as a routine tool to trim kind of ventilator settings?
Yes, we use every day to be the strain and the stress of the lung, parenchyma. Yes, you are like a routine. So 1.0 is our point.
So, for me, if I have everything available, I again do not rely on one factor, because with time we have learned that one parameter cannot really tell us. So I go with the combination of system, that is including the and then getting driving pressure. So not one parameter we rely on like in the ventilator, because I started learning. We know that every patient is different, every patient parameters are different. So there are times when only the driving pressure is not enough to see. We have to do the even pressure and repeat everything that action. So just reducing with some value, they are not able to read. So probably stress and strain is also not enough. You have to look every parameter and try everything at right place. That will be my statement right now. Other than I say, okay, I choose stress and leave everything, it's irrelevant. So we have to look all of them.
And I think, thank you, expert. We need to conclude as time constraints. The journey of knowledge sharing will continue. Thank you, Jenny ma'am. Thank you, Rajesh sir. Thank you, Dr. Nita ma'am.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गणशक्तिराय गणनन्दीशाय गणेशाय धीमहि तीव्रदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि ज्येष्ठाय भालचन्द्राय हिरण्येशाय धीमहि युगपन्थाय वक्रतुण्डाय गौरीतनयाय धीमहि ज्येष्ठाय भालचन्द्राय हिरण्येशाय धीमहि
interesting study which was in contrast to this was this feast trial. And this came from actually sub-Saharan Africa. This was a multi-center trial which enrolled almost 3,000 children, and they investigated the effect of fluid boluses versus no bolus in children with sepsis, primarily looking at a mortality of 48 hours. And they actually, very surprisingly, found that giving fluid boluses actually increased the mortality rate in these kids. So the impact was that fluid boluses, what they suggested was that fluid boluses might be harmful to certain populations, and this implied that there was a need for caution while using. And then came these three studies, which my younger colleagues might now be very aware of. Any exam you are taking, they are going to talk about this. These three trials, the process, ARISE, and PROMISE trials came around the same time, 14 and 15. One was from the US, ARISE was from Australia and New Zealand, and PROMISE was from UK. And they collectively enrolled over 3,500 patients and compared the EGDT, the EGDT has defined as the reverse trial, to the usual care for sepsis resuscitation. And all these three trials demonstrated that there was no significant benefit with EGDT over usual care. Now, EGDT, you remember, it was a single center trial, and this was a much larger population. So these findings actually led to a shift away from the rigid resuscitation protocol of EGDT and towards, as is happening with all our critical care medicine, individualized care of our patients and interventions, but it also allowed flexibility in fluid and administration. And